And I'm also an HIV ID specialist by background. So I feel like my passion is really interactions between these two infections and from both a clinical perspective and also a social science perspective. Next slide, please. So our learning objectives are, number one, to understand the importance of Hep B testing as part of your PrEP programs and also as part of PEP treatment after an exposure to HIV possibly. Number two, to understand that hepatitis B treatment with tenofovir-based therapies is also HIV prevention and what we can, how we can leverage that fact. Number three, to learn about hepatitis stigma in Zambia and how there is some association of HIV stigma with hepatitis stigma because of overlapping issues. Number four, emphasize the need for client-centered care for HIV negative individuals. Number five, to understand risk factors for HIV and hepatitis and to understand that integrated elimination approaches will be more effective and more efficient for our health system. Next slide, please. So just to refresh you, in case you haven't been tuning in to the hepatitis echoes, this is the most important data on hepatitis in Zambia, which comes from the Zambia 2016, which was, of course, it's an HIV impact assessment that was funded by PEPFAR, but it was for those of us who are interested in addressing hepatitis, it was really a wonderful thing to also integrate hepatitis B testing at a population level because some of the most useful data were generated. And so you can see from the 2016 Zambia that we estimated that overall the prevalence of hepatitis B was 5.6% among adults, that's 15 to 59 years old, and 1.1% among children, 0 to 14. So overall, we had something like with children with Hep B alone. And then you can also see there's a substantial burden of co-infection, 67,000 with co-infection among adults and children. And then these circles here just represent the fact that hepatitis B is not as common as HIV in Zambia. So the circle of hepatitis B, is just showing you that we have about half as many cases of chronic hepatitis B as we do for HIV. So it's just important that you appreciate the difference. But I think that the other thing we wanted to bring out is that this group that has co-infection here, where the two circles overlap, that tends to be the group with the most severe outcomes. And so this is why both hepatitis programs and HIV programs need to look closely for co-infection. Next slide, please. So the second refresher I wanted to give everyone is just on transmission, because this is the most common question that patients and their family ask. And everyone wants to know, where did this virus come from? How did I get exposed to it? And so hepatitis B is transmitted through sexual body fluids, but even more so through blood. And you can see here from this slide that the actual leading modes of transmission have changed dramatically since 2005. So what happened in 2005? 2005 was when our EPI program incorporated the hepatitis B vaccine into the package, into the pentavalent vaccine given to virtually all children being born in Zambia. And so you can see that before 2005, there were both maternal child transmission events and early childhood exposures. This is when kids are playing together or getting small bruises in the household, and they can get exposed to small particles of the virus. And so that pretty much went away after vaccination. So right now we're only left with mother-to-child transmission at the time of birth, when babies are exposed to mom's blood and body fluids. And then, unprotected sex is really the second mode of transmission. So when I have a patient in front of me who is born before 2005, that means most adults, they ask me, how did I get hepatitis? I say that most likely you had it when you were born or in early childhood. So you've been living with it for a long, long time. That's the most common scenario. Now, only those people who are very young and are found with hepatitis, then you might look at probably, again, mother-child transmission or rarely sexual transmission. So in Zambia, the vast majority did not get the infection from sex. So that's a really big difference from HIV. And I think if you go onto the internet and you start reading about hepatitis, most of the content is from other countries where they have more sexually transmitted hepatitis. But in Zambia, we don't have that much. Develops stigma, and they don't struggle to disclose to others. Next slide, please. Okay. So then my third part of the refresher is on treatment. So just to remind you, we model our program on the HIV program, if you will. So as you can see here on the left, the first thing is diagnosis and linkage to care. So when someone is tested hepatitis B surface antigen positive, the first thing we try and do is to link them to clinical care at a So in hepatitis B, we don't have universal treatment, but we treat according to eligibility. And so either someone is found eligible, or if they're not eligible, we ask them to return after 3 to 6 months to reassess their need for treatment. Once someone is found eligible, we usually prescribe lifelong treatment, just as we do in HIV. And you can see here the treatment options, and you'll recognize that those are all ARVs. So it's important to recognize that that certain ARVs, most importantly, tenofovir, either the DF form or TAF, are the most potent treatments for hepatitis B. And it's only really children who are too young or are not, don't have the right body weight to receive tenofovir, where we use lamivudine, i.e. 3-TC. Next slide, please. And present the case. Thank you.
Thank you. Good afternoon, Dr. Mike. Dr. Myangana here.
Good afternoon, Doc. Go ahead with the presentation.
All right, thank you. Okay, so the first case we're going to look at is that of MM, a 25-year-old woman who presents herself to a mobile clinic in Livingstone that was set up as part of a PrEP. She wants to learn more about PrEP. So she's a sex worker who meets truck drivers near the border while they wait for clearance to cross the border. She sometimes has up to 3 partners in a single day and rarely uses condoms. She feels well overall, but is interested in learning her HIV status. She felt stigmatized. Sorry for that. Okay, so I think we can launch the poll questions. Okay, so so the first poll question is, which of these is not recommended at the time of starting testing for hepatitis B, C, testing for HIV, and D, testing for tuberculosis with sputum expert? So I can see only 10 people have voted so far. Okay, so let's have those votes coming in. Okay, only 34 out of 63 people have participated. Okay, so the poll has ended, and from the results, we had the majority saying the answer is D, which is testing for tuberculosis with sputum expert. However, we still had some people polling in to say the one that is not recommended is a creatinine. Others, about 9% thought it's testing for hepatitis B, and we had 3% saying it's testing for HIV. That is not important. Dr. Mike, you can take over.
Thank you so much. Great. So yes, the point of this poll question is just to refresh that hepatitis B testing is strongly recommended at the time of starting PrEP. We can go on to the next slide. Thank you. Okay. So the point we wanted to make here is that the PrEP that we are giving in Zambia, which is tenofovir-based oral PrEP, is the same as we would give a person when treating hepatitis B. This is an adult. And tenofovir was actually found to be the most potent antiviral medication against the hepatitis B virus, more potent than lamivudine or emtricitabine. And there are several other drugs which are not available in Zambia, but generally tenofovir is very potent. On top of that, the hepatitis B virus does not learn how to develop resistance against tenofovir. So it's a really wonderful drug for us treating hepatitis B, because even when patients struggle with adherence and retention, we don't really have to worry about switching them to a second line, because the tenofovir remains potent even after periods of inadherence or disengagement from care. So why do we care about checking hepatitis B status when starting PrEP? These are the couple of reasons that we encourage you very strongly, if it's available in your facility, to make hepatitis B testing part of the PrEP enrollment process. So the first reason is that it's important to make the patient aware, if they are positive for Hep B, that the PrEP would have multiple benefits. And so, we think of it as killing two birds with one stone. So I know that I'm not a PrEP program manager, but I know that one of the challenges that PrEP program faces is continuation, keeping people on PrEP for long. And so if the patient learns that they also have hepatitis B, then they can be, you can use that as a way in counseling to say that this is having multiple benefits. It's not only keeping you HIV negative, but it's also treating your hepatitis B and keeping your liver from developing cancer. The second thing is that it helps you, I think, programmatically to encourage retention in the programs. So patients who are Hep B positive and going on PrEP, it should be made aware that even if they change their sexual behaviors, or whatever behavior is putting them at risk for HIV, even if they change in the future, they still need to be a patient at the clinic, because they'll still need to be followed up for hepatitis B related monitoring and care. So again, this can be incorporated into the program as a way to enhance the retention of the clients in the program. So there will never be a time when you would discharge them completely from the PrEP program. So you'll still need to retain them. And then finally, the third reason is just for safety, because some people who are Hep B positive have underlying cirrhosis, which is advanced liver disease. And if they were to start taking treatment, i.e. PrEP or tenofovir, and then they stop suddenly, they can get very sick from a hepatitis flare. So it's also important that you tell them, in case you do want to stop in the future, we do recommend you continue to follow up with us so that we can just monitor your liver and make sure you don't have a flare-up of your hepatitis. So these are at least 3 reasons why we think it's very useful to go ahead and do that testing at the time of starting PrEP. That being said, there's no reason to delay PrEP. If you don't have a hepatitis test available, or if you're waiting on results, there's no reason you shouldn't give PrEP. You don't have to delay. But this could even be done on the 2nd visit or the 3rd visit. But we certainly recommend that all people know their hepatitis B status. Next slide, please. Okay. Yeah, so I think there's something missing from the box. So I think that the next thing we wanted to go over was actually a case series that we performed at UTH. So at UTH AIDC, we have started a hepatitis B clinic, which is happening every Friday. And we usually book between 15 and 20 patients to that clinic. Half of them are new, half of them are returning patients. And we did an analysis of about 160 patients who had at least 1 year of follow-up. And as you can see here, from the 160 patients, only 30 were not eligible. And what we noticed during our 1 year or 1 year plus of follow-up was that 5 people who were HIV negative at baseline actually seroconverted to being HIV positive during the follow-up period. And so we recognize this issue. We tried to analyze and understand what happened. Can we go? The full slides are not available. I think there was a figure there that got deleted. But the first reason was one client that actually, he was eligible for therapy, but by the time he came in to start therapy, about 5 months had passed, and we did not reassess his HIV status before he started therapy. And so from the basis of this case, we now strongly recommend in our hepatitis programs that before you actually, on the day of initiation, ideally, you would recheck the HIV status, just like you do in the PrEP program. So I'm pretty sure that in the PrEP program, before you give out the next 3-month refill of PrEP, you do an HIV test there and then, just to be sure. And so in hepatitis B, we are now adopting what you guys do. And so when we prescribe, we just recheck the HIV status just to be sure. Next slide, please. Then we also had 3 patients who were not eligible. And when we looked back at their records, we realized that, we didn't really assess any of their sexual risk factors for HIV. And so probably we were just looking at their livers and their hepatitis. So they were never given treatment. And so unfortunately, this was, again, a missed opportunity to prevent HIV, because now one year later, when they came for review, now they had turned 18. Like what you're doing in the PrEP program in hepatitis, we should also assess risk for HIV. And in case someone is not eligible for hepatitis B therapy, but they do have some sexual risk factors, then that might be an indication to initiate them on treatment. Next slide. The last patient, so again, out of the 5 who seroconverted, the last patient was one who was actually on treatment for many years for HBV. But what we found out was that his adherence had been very poor. So he was collecting medicine, but his viral loads never reduced. And it turned out that he really wasn't taking his medicine appropriately, and he got exposed and infected with HIV. So, so basically the take-home messages for the hepatitis program are that, again, like I mentioned, we're learning from the PrEP program, and before we prescribe hepatitis B treatment for the first time, we make sure to recheck the HIV status. And this would also go for a patient who disengaged from our hepatitis care and is now returning for treatment. We would always recheck the HIV status. And then secondly, when we are revising the hepatitis guidelines in the future, we will probably include a section about PrEP, about HIV PrEP, and we'll say that patients with hepatitis B who have ability. So whether it's PrEP or hepatitis B therapy, they're one and the same. And so I think it's just something that we have now become really aware of in our hepatitis program. Next slide, please. Okay, and then I think that the purpose of this slide, hepatitis B treatment in pregnancy, is to also talk about the fact that an advantage of treating hepatitis B in pregnancy is also PrEP. So as I mentioned before, mother to child transmission. This happens usually peripartum transmission at the time of labor and delivery, because that's when the baby is exposed to mom's blood and body fluid. So you can see that if the mom has hepatitis, there's lots of opportunities to expose the baby. And the EPI program that provides vaccines doesn't come in until 6 weeks of age. So there's a gap there where some transmissions are happening. And so as a program, and I know that even the PMTCT program is working on this, we're trying to think about how to enhance hepatitis B PMTCT in Zambia. And one of the arguments is that if we aggressively give treatment to pregnant moms, they'll not only reduce transmission of the virus to the babies, but they'll also keep the moms HIV negative in pregnancy. And some of you I know are experts on pregnancy and HIV, and my understanding is that pregnancy is a high risk period for women to be exposed to HIV. A very efficient, integrated type approach for them. So that's certainly something that is not in our guidelines as of yet, but if I were seeing a pregnant woman with hepatitis B today, I would certainly consider that. Okay, this is poll question 1. Next slide. There is another question coming in. Okay, and then this is a little future looking, but injectable forms of PrEP that are in the pipeline may come to Zambia in the near future. And so clinical trials were done evaluating an intramuscular injection of an ARV called cabotegravir. And the injection was given once every 2 months into the muscle. And that injection was compared against what we're doing now, which is probably the reason for that was because of better adherence. You have just one injection every 2 months rather than taking a pill every day. So that's a really exciting thing that's in the pipeline. However, as a hepatitis B program, we're going to continue to recommend hepatitis B testing because the cabotegravir does not have activity against the hepatitis virus. So as we start to implement this in the future in Zambia, we're going to need to be aware that it doesn't have the same hepatitis B advantage that our tenofovir does. And so I don't know exactly how some clients who are happy to have either might be recommended to be on the oral one if they have hepatitis B. That could be one approach. But I just wanted to mention this as you're thinking about, I know some of you are working on PrEP and they might, just to recognize that the PrEP that is injectable does not have hepatitis B coverage. Next slide.
Okay, so the slides have changed. Maybe we, okay, thank you. So this is our second case scenario, and it's that of BD, a 47-year-old nurse who was referred for PEP. She was bleeding a patient in ART clinic where she works when she stuck herself when recapping the needle. The client is known to have HIV, to have HIV, taking ART, and also has hepatitis B. The ART in charge opens a file for BD and then sends her for HIV testing and hepatitis B virus testing. Okay, so the poll question is, of these is recommended when managing a person on PrEP or PEP who is found to have hepatitis B virus. So that is their hepatitis B surface antigen positive. A, you withhold PrEP or PEP until the results of the hepatitis B virus viral load. B, you do liver function. C, once starting, never stop PrEP or PEP in a person living with hepatitis B. D, cancel the person that PEP or PrEP has two benefits for, so has two benefits for them, that is preventing HIV and treating hepatitis B virus. So we can start polling in, and E is both. Okay, so from the results, we can see that the majority of our participants polled in to say the answer is E, which is both to do liver function tests and to cancel the person that PEP and PrEP have two benefits. So answered that polled in to say the answer is A, which is to withhold PrEP or PEP until the results of the hepatitis B viral load are out. And a number of people who also polled in to say the answer is D, to cancel the person that PrEP or PEP has two benefits for them, that is preventing HIV and treating HPV. Back to you, Dr. Mike.
Thank you so much. Yeah, this was a tricky question. And so, yeah, so this is the scenario, which is this is a nurse who was stuck by a needle. And this is very common, actually. I think that there was a master's student at UNZA who did her thesis on needle sticks. And they said that they were stuck by a needle while they were working as part of their, during their time nursing. So it's quite common scenario. And when this happens, both HIV and HPV. And this is a question about how do you manage if that Hep B comes out reactive. So the first thing is that even if Hep B is reactive, if HIV is non-reactive in a PEP client, you do need to initiate PEP right away, because PEP there's no reason to withhold or delay the giving of PEP, because the main reason for PEP is to prevent HIV in this case. And the second thing is, if you have the client in front of you, they're going on PEP, but they have Hep B, it's a great opportunity to send them for some basic blood tests. A full blood count as a kind of a minimal test. The reason for that is that you later, if they need to stop PEP, you would love to know whether there would be benefits of them continuing treatment for Hep B. That's part of our eligibility criteria. Then the third option was now when the Hep B is very mild, and if there's no indication to keep them on tenofovir for PrEP or PEP, then you might actually want to discontinue it. So I wouldn't say never stop. And then finally, the last option, D, is correct, because again, when you find a patient who has tenofovir-based therapy can prevent HIV and also has the second benefit of treating your hepatitis. So again, just like in the PrEP program, there's a lot of intersection in the PEP program. And I would also say that as part of our UTH AIDC Hep B Clinic, a lot of our clients are actually health workers, which is very interesting because I think that many people who yeah, so basically, here's a summary of the recommendations. So if you are doing PEP with a health worker in your facility, the first thing is to, just as you're doing the HIV test, you should get a rapid Hep B test. These testing you can get the result. And then number two, if they are testing HBV positive, help them to enroll in the program and open a file so they can be followed up long-term. Number three, you would start PEP immediately, just as you would for anyone who you're trying to prevent HIV. And then the final thing, B exposure, in addition to PEP, you would also give a dose of Hep B vaccine. So if you were just setting up a PEP program to prevent Hep B, you would say you would still give the tenofovir-based therapy, but you would also give a dose of vaccine. So the vaccine can help prevent HBV from occurring. Next slide, please. Okay, next slide. All right, so this is the last section that we're going to go through this afternoon. So it's about psychosocial factors related to HBV disclosure, testing, and treatment. Next slide. This is going to be difficult because there were a lot of quotations here. Can you go to the next slide, please? Yeah, maybe I will have to share them from my end. Just a second.
Apologies, Dr. Vinikoor. We'll stop sharing now. Thank you.
Okay, I'm assuming that people can see this. So I thought you would appreciate seeing this data. So within, again, our UTH AIDC clinic, we did interviews. Yes?
Sorry to interrupt you, but the slide is split in two, so we can not see the slide in its entirety, just half of it.
Okay, let's see.
Let's see if we can get the other slides up. Hold on.
Is that any different?
Yes, it's perfect now. Please go ahead.
Okay. Okay, great. So to understand about some of the psychosocial issues around hepatitis B, we interviewed 79 people from the UTH AIDC Hep B Clinic to understand their experiences living with the infection and disclosing their status to others. And so here's a quotation from one female related to disclosure. So in general, people said that they preferred to disclose their hepatitis status only to very close partners, and that sometimes the disclosure actually led to the end of a relationship. So this quotation, a woman said, "Apart from my husband, no one knows I come here for hepatitis because there's stigma. And they know that this thing is infectious. Just like my sister, other participant there, it's sad that the husband left because she was put on treatment ART." We also recognize from these interviews and focus groups that there's low awareness of Hep B in the general population. Here are some quotations. A female or a woman age 51 said, "The time when she found out that she had hepatitis B, it was easy for her to accept because she did not have any information about hepatitis B." And then another woman, age 55, said, "When my mother discovered that she had hepatitis, that's when we asked the people who work at the clinic. They were surprised. You should bring her back to the doctor who tested it. Didn't know the medication had been administered. This medication is for people who have HIV, not hepatitis." So generally, there's not a lot of awareness of hepatitis, and because the medications are the same, people can easily confuse the two infections. Also, as I mentioned, many of one of our clients in the Hep B clinic at AIDC are health workers themselves, and they reported using their occupation as a way to reduce stigma when disclosing their status. So one male laboratory worker said in the interview, "When I told my wife that I'd been diagnosed with hepatitis, then it came in the mind quickly that I think you're promiscuous. The element of promiscuity came in and I was stigmatized. It was very bad until I had to bring my wife to the nurse for some counseling and assurance that it's not as you think. Since this man works in an environment where he handles a lot of patient samples in the laboratory, this could be very much the area this disease could have come in." And then a nurse, age 30, said, "As for me, I was just saved by my career because if I wasn't a nurse, people would have thought HPV was sexually transmitted." And then here's another quotation that relates to the similarities between Hep B and HIV and stigma in Zambia. So a young man, age 18, said, "My family knows nothing at all, really, so I realized. In fact, they came to know about it, hepatitis, after I told them about it. I didn't even know it was there until I was diagnosed with it. When I explained to them that it's transmitted most like AIDS, they got scared. And when I told them that there would be a point when one has to take medications just like AIDS, that scared them even more." And the other thing that we have seen in our experience at the clinic is that disclosing is difficult, but once people go on to ARVs for their hepatitis B, things become even more challenging. So here are some quotations. So one woman, age 33, who went on to treatment for hepatitis B, she said, "When you tell them that HBV is more dangerous than HIV, they don't understand. And when they see those drugs for HIV, they think you're HIV positive. Like last time, my brother went there to take some drugs at the hospital for HBV, and he was in the same line with HIV patients." A woman age 30 also said, "Before I was put on medication, all was well. But after my husband, discovered that the medication which I was given, these ARVs, then he said, 'No, you're lying. You're HIV positive. You have to find someone who's Hep B like you, because it's not an easy thing. It will be very difficult for me to understand you and be with you. Allow me to find someone who's negative, since I'm negative. I can't be staying with someone who's taking ARVs.'" So again, I think these are very useful experiences for us to learn from. And in general, as a program, we find it very convenient to use the ART pharmacy at AIDC, and we follow very closely with what the HIV clinic does. But a lot of times our patients, they struggle with that because if they don't have enough education about hepatitis B, they think that they don't understand why they're being sent to the HIV pharmacy, why they're being sent to the HIV clinic. And it's very hard for them to disclose and explain why they're taking ARVs for something other than HIV in Zambia. And so, and at least on several occasions, they've even requested to say, can you take my ARVs out of the bottle and put them into a different packaging so that my relatives who see the medication don't think I'm HIV positive and I'm lying to them. All right, back to you, Doctor, for the last poll. Dr. Asombang, I think you can go back to your slides now.
Okay, thank you.
Okay, the third poll question reads, what causes hepatitis B virus to receive stigma by its association with HIV? A, both are viral infections that spread person to person. B, both are treated with ARVs. C, both can be transmitted through high-risk sexual contact. D, both can be life-threatening if not adequately treated. E, all of the above. So thank you to those that are calling in. So far, we have 17% of the network having called in. Okay, we still have less than 20% of the less than half of the network calling in. Okay, so the results are that the majority of the people say the answer is E. That is representing 79% of those that answered. To say all of the above, we had 18% saying the answer is B, which is both are treated with ARVs, and 3% thought the answer is A, and that is both are viral infections that spread person to person. Your comments, Dr. Mike?
Yeah, thank you. So I think that this is a new area, and I think probably many of you are hearing it for the first time, but you won't be surprised that there is stigma. There is hepatitis stigma in Zambia. Even though awareness of the infection is relatively low, which usually low awareness actually sometimes can equate to low stigma. But there already is some misinformation and some difficulty in this area. And you can see here that when people learn about their status and they start understanding what it is, again, it's an infectious disease, so that leads to stigma. The second thing is that the treatments are one and the same with HIV and with PrEP. So whenever we prescribe ARVs to a person with hepatitis B, we have to do a lot of health education so that they're really understanding why we're giving them ARVs. We've been accused on multiple occasions of trying to coerce people onto treatment where they think that we're lying, that they're HIV negative. Like, why are you giving me ARVs when I'm HIV negative? So just requires a lot of health education when we do this. And then, I think that there's also an association of hepatitis with cancer and with mortality. And so again, that leads to a lot of fear and anxiety. And so as we are expanding the hepatitis program, we're trying to learn from these early cases and early experiences so that we can make sure that the program can cater to the needs of our patients. And I think I'll stop there and pass back to Dr. Asombang. Thank you very much.
Thank you, Doctors Vinikoor and Mweemba. That was very informative. And as we approach HIV and hepatitis B, we definitely need to put that into consideration. And so right now is our Q&A discussion. We have about 10 minutes left on the clock. And so if there are any questions, please feel free to unmute yourself. I'll also be looking in the chat box just to see if there are any questions. Okay, so I have one hand raised from Laston Chitembo. Please go ahead.
Good afternoon for this very important topic and excellent. I'm just wondering what our plans regarding the Zambia consolidated guidelines for HIV prevention and treatment, which I'm not sure if it's ready. If we still have time, if you go back to slide number 6, if that's okay.
Sure, just give me a moment. Hold on a second. We're turning to slide number 6.
Okay, thanks. This is a very good, I think, algorithm or eligibility flow chart, which we could actually include in the Zambia consolidated guidelines. So the question is, do we have time? If so, if we can be given a chance, can we push this? Then number 2 is there is the issue of eligibility for HPV treatment. Somebody is HPV positive, but not eligible. But however, they are high risk. And then we want to make sure that they don't miss the chance of HIV prevention. And so we start them on HPV treatment much earlier, which is not in the guidelines. I think that's one of the slides coming after this slide. It was shown there that this is not currently in our guidance. Can we also consider inclusion of that in the Zambia consolidated guidelines? Thank you.
Thank you for that comment. I'm not sure if Dr. Vinikoor, do you have any rebuttal to that?
I think the chair of the guidelines, Dr. Sinkala, is on the call. He can respond even better than me.
Thank you very much, Dr. Chitembo and Dr. Vinikoor for that. Yes, this high-risk group is our worry as well. Well, this is up to us for to see if this is something worth doing, because these are local guidelines are up to us to decide. It's good that it's coming from Dr. Chitembo, who normally we sit together even when we do some of these guidelines. Like last time we were doing Hep B guidelines, we were together. So it's something we can really consider and see if we can factor it in the local guidelines. Thank you.
Thank you, Dr. Sinkala. And so I'm going to direct us to the chat from Dr. Zachary. Thank you so much, Dr. Vinikoor, for those wonderful testimonies that really highlight the work we still have to do to reduce stigma. If there will be time at the end of it, it would be interesting to hear from the network what, if any, strategies they are implementing to reduce stigma. And so I'm going to throw this question back to our network. If there's anyone who has been implementing any stigma prevention in regards to our hepatitis B or HIV patients, please do inform us. Thank you, Dr. Zachary. By the silence, I'm going to consider that no one is implementing any strategies to reduce stigma. And so I will encourage us as individuals and also in our capacity as health workers to advocate for stigma prevention amongst this cohort. I'm not sure if there are any other comments from our experts. If so, please do chime in.
I would just say that at UTH, we recommend our clients to bring in their family for testing for hepatitis. And we really emphasize on hepatitis B as a family disease, not as a sexually transmitted disease. Because as I said, the epidemiology would indicate that most people were exposed at birth or at their households, not through high-risk sexual activity. So therefore, I think we just really focus on trying to take a family-centered approach to the condition. And I think that really helps. We also have a lot of families in our clinic, where it's husband and wife, or mom and children, or brothers and sisters. And so I think just sharing that with the other clients reassures them and helps them to disclose.
Thank you so much, Dr. Vinikoor. We also have a comment from Dr. Simuyandi. I am suggesting that the drafting or moving forward, we could task the TWG on viral hepatitis to drive this. And so this is just another encouragement from our network for us to implement this. We have about 4 minutes on the clock. I'm not sure if anyone has anything else to add from our experts. Please do feel free to go ahead, or if we have any other questions or comments, please do unmute or raise your hand and I will call on you. Okay, so we are gonna conduct a repoll of all the questions we asked, just to see whether or not people were paying attention. And so we'll start with the first poll. Just give it a second. Okay, there you go. Dr. Myangana, if I may ask, please go ahead and take on poll 1 for us. Thank you.
Okay, so poll 1 was relating to a sexual worker from Livingstone who had presented to a mobile HIV testing clinic, and she wanted to receive PrEP. So she had heard about PrEP from one of her workmates, and she wanted to receive the service. So the question is, which of these is not recommended at the time of starting HIV PrEP? A, creatinine; B, testing for hepatitis B; C, testing for HIV; and D, testing for tuberculosis with sputum expert. Okay, so far we have 24% of the network participating in the poll. Okay, let's get polling in. Okay, just a few more seconds before we close the poll. Okay, so the poll has been ended. So we have 86%, 86% saying testing for tuberculosis is what is not recommended at the time for HIV testing. However, we still have 10% of the respondents thinking creatinine is what is not recommended, and 3% saying hepatitis B testing is what is not recommended. So Dr. Mah, is there going to be a comment on the poll, or we can move on to the next one?
We can move on to the next one because we're running out of time.
Okay, thank you.
Thank you.
Okay, so the second poll, the second poll was relating to a healthcare worker who had a needle prick injury whilst she was drawing blood from an HIV positive and hepatitis B positive client. So the question is, which of these is recommended when managing a person on PrEP or PEP who is found to have hepatitis B? So A, withhold PrEP or PEP until results of the hepatitis B viral load are out. B, do liver function tests like ALT at the time of starting PrEP or PEP. C, once starting, never stop PrEP or PEP in a person living with hepatitis B virus. And D, cancel the person that PrEP or PEP has two benefits for them: preventing HIV and treating hepatitis B virus. E, both B and D. So E is both doing liver function tests and counseling on the benefits of PrEP and PEP. So we can start answering the questions. Okay, let's keep those answers coming. Okay, so the poll has been ended, and from the responses, we can see that the majority, that is 91% of those that poured in, thought the answer is E. That is both B and D, and we have about 5% thinking the answer is C and 5% thinking the answer is D. So.
Thank you, Dr. Muyangana. There's just one more poll to go, and then we will adjourn.
Okay, so finally, we have poll question number 3, which is related to stigma in hepatitis B and HIV. And the question is, what causes hepatitis B virus to receive stigma by its association with HIV? A, both are viral infections that spread person to person. B, both are treated with ARVs. C, both can be transmitted through high-risk sexual contact. D, both can be life-threatening if not adequately treated. E, all of the above. Okay, so far we have 24% of the network participating. Okay, let's pour in. Okay, just a few more seconds to go. Okay, so the poll has been ended, and 91% of the network thinks the answer is E, which is all of the above. And we have 5% thinking the stigma is because both are treated with ARVs, and 5% thinking the answer is D, and that is both can be life-threatening, not adequately treated. That is all for the polls that we had. Thank you for your participation.
Thank you so much, Dr. Mweemba, and all of our experts, Dr. Vinikoor as well. We are grateful for the time you've taken to inform us about HIV, hepatitis B, PrEP, PEP, and stigma. And so we have gone a few minutes ahead of time, and so I do apologize, but thank you so much, everyone, for taking your time to join today's ECHO session. And please continue to keep abreast of the sessions that we'll be having in future. Take care.